APICON 2024 highlights. The Bix rule. In an SVT, where P wave is exactly midway between two QRS complexes, suspect that there is a P buried in the QRS, so atrial flutter with a 2:1 AV block is suspected. In an LBBB, notching in an upslope of S wave at 40 milliseconds in V3 and V4 indicates an MI. This is the Cabrera sign. Chapman sign. There's a notch in the R wave of 1 AVL and V6 and it indicates an MI in the setting of an LBBB. Crochetage sign. Notching of 2, 3 and AVF in the setting of an incomplete RBBB is indicative of an ASD, especially the ostium secundum type. De Winter sign. Downsloping ST depression with tall peak T waves in the anterior leads. It indicates very proximal LAD occlusion. Take straight for a CABG. Dressler beat, fusion or capture beat. It indicates there are two pacemakers, one from the SAN and one from the ventricle. So the ECG is of ventricular tachycardia, not SVT, with a bundle branch block. Double QRS or Epstein's anomaly. Himalayan or giant P waves of more than 5 millimeters in lead 2. If seen in 3 and AVF and in V1, there is gross right atrial enlargement. Suspect Epstein's anomaly if there is a wide RBBB but no tall R waves, Himalayan P waves, and a double QRS. L-Sherif sign, RSR- pattern in V3 and V4 in apical ventricular aneurysm. Reverse stick or hockey stick sign is the digoxin effect. The differences between digoxin effect and digoxin toxicity. There's a scoop ST, biphasic T, and terminal portion of T is above the baseline in a digoxin effect, while there's a downsloping ST T inversion and terminal T is below the baseline in a digoxin toxicity. ST-T changes are seen only in positive QRS complexes in a digoxin effect, but ST-T changes are seen in negative QRS complexes also in digoxin toxicity. Fractured QRS in multiple leads, indicative of myocardial scarring and predicts risk for arrhythmia. Goldberger sign, tall R waves in AVR in persistent ST elevation, suggestive of an LV aneurysm. Goldberger's ECG criteria for DCM: LVH in anterior precordial leads, low voltage in limb leads, poor precordial R wave progression. Himalayan or giant P wave of more than 5 mm in lead 2. This is indicative of Epstein's anomaly. Josephson sign. Notch in the downslope of the ST, which confirms that it is a VT. Another way of telling it's a VT, the AVR is positive. Lead 1 sign in severe COPD. Investigate lung rather than the heart. Knuckle sign seen in acute pericarditis. PR-ST discordance is present. If the PR is up, the ST is down. If the PR is down, the ST is up.